Hello everyone, my name is Dr. Mushraf Fawzi, and in this presentation I will talk about temporomandibular joint disorders, TMDs, so I will always refer to them as TMDs, and I will focus on the etiology and classification of TMDs. So those are the references which I use to make this presentation. They are both textbook. One is the TMJ disorders and orofacial pain, the role of dentistry in multidisciplinary diagnostic approach. And the other one is TMD and orthodontics, which is a good book for orthodontists. So temporomandibular joint is a very special joint. It's a synovial joint, and it's composed of several parts. The first one is the condyle and the glenoid fossa, which is part of the temporal bone, and between them we have the articular disc, and this articular disc is attached anteriorly and posteriorly. Anteriorly is attached to the lateral pterygoid muscle, and posteriorly is attached to a retrodiscal part, which is a fibrous tissue. And the most important part is this articular disc, which moves whenever the joint or the jaw is opened and closed. Whenever anything goes wrong in this joint, we will have TNDs. So TNDs, they are a group of disorders that have their origin the musculoskeletal structure of the masticatory system. Therefore, symptoms of TMDs are associated with either the muscle of the mastication or the temporomandibular joint, or both. Pain can be a common symptom which is associated with. So, depending on which epidemiologic studies are reviewed, the number of signs and symptoms associated with TMDs range from 40 to 60% in the general population, which is really a high number, depending on the way of registration of the signs or symptoms. So some studies consider minor symptoms as the TMDs, while others only consider severe symptoms. And only 10 to 15% requires a professional treatment. So with TMDs, we have two broad conditions. So either we have muscle pain disorder or intracapsular disorder. Both of those conditions, they differ in the etiology, pathology, and the clinical presentation. However, muscle disorder is twice as common as intracapsular disorder. So for many years, there has been a controversy about the etiology of TMDs. So first is the occlusal factors. Recent data do not support the traditional belief that a static relationship of teeth is strongly associated with TMDs. And this is something related to orthodontics, like in patients with deep bites and class 2 and cross bites and eccentric contacts. When we have this condition, it's not necessarily to have TMDs. So two ways that the occlusal relationship of teeth and TMDs are related. First is an acute change in the occlusal condition. For example, when you are doing a filling or a crown and you have a high spot, and this will cause muscle discomfort, and eventually it will cause pain. So it's a muscular pain that will subside when the high spot is removed, and if it's the high spot remain, then you will have TMDs. The second thing is occlusal orthopedic instability, which is coupled with loading, usually, and intracapsular pain associated with this etiology. And what I mean by orthopedic stability, so every joint has its musculoskeletal stable position, and this is the position is defined in the TNG as the condyles resting on articular eminence with the disc correctly positioned between those articular surfaces. So orthopedic stability in the masticatory system is present where the teeth, when the teeth are in their stable biting position, at the same time the joint in their stable position. So if we have instability between those positions, then definitely we will have TMDs. And a common type of thing that will happen are the fibrous connective tissue breakdown and bone degeneration, clicking. So the second reason is trauma, and intracapsular changes might happen. So a single blow to the face can immediately change the structures of the joint, resulting in intracapsular issue. This is called macro trauma, and the acute occlusal change is called the micro trauma. And the third reason is emotional stress. So acute emotional stress can increase the muscle activity, electromyograph activities of the masseter muscle, that will lead to muscle fatigue, tightness, and pain. The fourth reason is deep pain input. So any source of neural impulses that originate in the deep structure can lead to a pain experience, excluding the skin and oral mucosa. So the pain has a unique characteristics of triggering the muscle structures, and a common example is cervical pain. Is also called a whiplash, like a sudden movement of the cervical vertebrae, and clinically it's evident when you have limitation in the mouth opening and pain. The fifth reason is parafunctional pain. So for many years, dentists have focused on bruxism and clenching as a significant factors for causing TNDs. Clenching is biting during the day, while bruxism is biting during the night. And usually, teeth come in contact with the normal person and for 45 minutes and 24 hours. And imagine 5 hours of continuous loading and pressure on the teeth. This will represent 500 to 700% more pressure and contact between the teeth than the normal condition. Most of the time, this can lead to TMDs. So the classification of TNDs. So TNDs in general falls into one or two broad categories. So either we have muscle pain disorder or intracapsular disorder. So first is the masticatory or muscle pain disorder. So patients experience masticatory muscle pain will describe the pain in terms of ranging from a slight tenderness to extreme discomfort. So the etiology of this type of disorder is still debatable, but most of the studies, they describe that excessive muscle use can lead to tiredness and fatigue, and this is justified by vasoconstriction and accumulation of metabolic waste products and the release of allogenic substances like prostaglandin, which will eventually cause muscle pain. So clinically, a significant clinical symptom is that the pain increase with function. So the patient will report that the pain affects their ability to chew and talk. There are 5 different types of masticatory muscle disorders. These are muscle splinting, local muscle soreness, myofascial trigger point pain, myospasm, and a chronic centrally mediated myalgia. So we will focus on local muscle soreness and myofascial pain. Local muscle soreness might happen due to overuse or trauma. So most common type of pain which is seen in the dental office is this type of pain. It is characterized by changes in the local environment of the muscle tissue, and these changes arise from the release of certain allogenic substances such as bradykinin, substance P, and histamine that produce pain. So clinically, the muscle is tender to palpation, and the pain increased with function, and some patients may report limited mouth opening due to pain. Myofascial pain or regional pain is characterized by a local area of firm, hypersensitive bands of muscle tissue known as a trigger point. Clinically, the region is very sensitive to palpation and have local rise in the temperature. So what's different from local muscle pain is the high sensitivity on palpation and increase in the temperature of the muscle. The second category is temporomandibular joint disorders, and the most common signs is a clicking and deviated opening. It falls into 2 groups. First, internal derangement is a group of functional disorder that arises from abnormalities in the anatomy or positional relationships of the TM joint structures. Most likely it arises from abnormality in the articular disc. The second group is osteoarthritis, which is degenerative joint disease. It's a disease, it's painful, and jaw movement accentuate the symptoms, and multiple joint sounds. We will have a crepitation of the joints, and it's often associated with disc displacement or perforation, and radiographically the surface will be eroded and flattened. At the end, take this home message: malocclusion is not always the causative factor of TMDs. Thank you for listening.